So should we start, sir? Divya, sir, is it? So very good evening. And on behalf of IAP Mumbai, I welcome you all to this ninth episode of the second season of Webflix series. As we all have been updated that this is a very open series, open discussions happen on this platform, which is staged on every last Friday of each month. And specialists and experts from a super specialty related to pediatrics are called, which is moderated by one of the persons from our team. And of course, the forum is very much open to discussion to and fro. It pertains to all the common problems in pediatric practice at office to a general pediatrician. So today our topic is on pediatric ENT, and of course our expert doesn't need any introduction. So a very warm welcome to Dr. Divya Prabhat sir. And sir has been an undergraduate and postgraduate from the most prestigious St. GS Medical College and KM Hospital, Mumbai. And thereafter, he went on to do his training in surgery for deafness and cochlear implants at initially at Germany and then at the Royal Australian Hospital at Melbourne. And sir, of course, is an author of 4 exclusive books on ENT. I'm sure most of us have read and referred to his textbooks. Few of us as undergraduates also and postgraduates. And I just came to know that sir's one of the books on practical ENT is in its 11th edition now since last 34, 35 years. So I think that's tremendous and that speaks of the kind of work sir has been doing and contributing to ENT. He's the sole section editor and the sole author for all the chapters of pediatric ENT in all the possible IAP textbooks that we know of. And of course, sir is an honorary and sir is the head of the department at Wadia Children's Hospital. And beyond that, he goes to Jaslok Hospital, he goes to Bhatia Hospital. And I mean, nothing more can be said about sir. So welcome, sir. Thank you so much. And to moderate, sir, today we have our EB member, Dr. Neeta Jagad, madam, who is very crisp and clinically oriented when it comes to common practice in office. So without taking much time, I think Neeta Ben, let's take over. And most of the people would know that she would just kick off the discussion on the common topics, the common problems in pediatric ENT that we don't miss out. But everybody is free to put up their questions in the chat box, which will be taken up by her from time to time. Thank you. Neeta Ben, over to you.
Thank you. Thank you, Dr. Nehal. I'm pleased to welcome Dr. Divya Prabhat, is a senior and renowned ENT surgeon. And thank you for your time, Dr. Divya. The format of the session, as we all know, is question and answers by an expert. Okay, request the audience to write your questions in the chat box and we will take it up all maybe at the end or from time to time, as Dr. Nehal said. And hope you all enjoy the session. Let us start with the science right away. So, Dr. Divya, can you please tell us what are the equipments must have in pediatrician's office for ENT examination? And can you please highlight the technique of how to examine the ear?
Yeah, first of all, thank you, Dr. Nehal, for a very kind introduction. Dr. Neeta and all my colleagues, friends, both Dr. Rajesh. See, basically all of you, obviously I should not say that we all have a tongue depressor, a torch, and I mean, general things, Cheto, everybody has in that clinic. But specifically from the ENT point of view, you should have a good headlight. A headlight is very important while examining children for the sole reason that your both hands are free to examine, because many of the things in ENT, which you will be either to visualize or to even, treat, or like maybe a foreign body or visualize the throat. If you have two hands, you'll be more comfortable in handling. So a headlight is very important, and a good headlight costs just 3,000 rupees. It's not you require a surgical headlight or something of that sort. Then, of course, otoscope, which all of us have. So the best way out is first see all children, even with no ear complaints, also see their ears. So once you have seen, 15, 20 normal ears, automatically you will get a hang of seeing the ears and otoscope. And to visualize the ear, see, as you know, in the ear, the cartilages in the bony canal is not in a straight line. So you can't visualize the drum. So in children, we require to pull the pinna downwards and backwards, and that pulls the cartilage gets in line with the bony canal, and then you can clearly visualize the eardrum. So before visualizing, you need to pull the pinna downwards and backwards, and in the older children, upwards and backwards. So the positioning is important to visualize the eardrum. Then for the ear, we require a vectis. A vectis is a very useful instrument. It is used to remove wax, fungus, or even a foreign body from the ear. And it's totally atraumatic, so you can, comfortably use it. A vectis or a wax hook. In fact, a vectis is better than a wax hook to be used. And lastly, of course, a syringe. And even if you don't have a syringe, you can use a 10 cc or a 20 cc, syringe to just clean out the ear in case, you're using it for wax removal. So these are the things which are important, which we require in our clinic directly, to manage our children. Then a tuning fork all of us have. So, I mean, it's nothing really specific about it. Now, when we consider the nose, to remove any nasal foreign body, we require a nasal hook. It's like a hockey stick instrument, or we also call a eustachian catheter. It's a long curved instrument, because again, the commonest mistake is that whenever we try to remove a nasal foreign body, we tend to push it inside. It'll go because the floor of the nose is in that direction, and the child will obviously move when you try to remove it. So you have to take support of the foreign body and remove it so that it does not slip behind. So you require a long curved instrument, something like a hockey stick, which we call a eustachian catheter. And another useful thing is that you should have gel foam with you in your clinic. For any child coming with an epistaxis, it's a life savior. You can just take a small piece of gel foam, whatever size, put it into the nurse. It's not only hemostatic, it is painless also, and it dissolves on its own. So any bleeding, epistaxis, or even ear bleed, just put in a small piece of gel foam and forget about it. So it dissolves on its own. So these gel foam will also be a very useful tool, if you keep it in the clinic. So these are the specific things extra apart from your routine armamentarium that if you keep in the clinic, it will be useful in your day-to-day practice.
Yeah, so thank you. That was really nice. And can you please explain about hearing screening at birth? So we almost nowadays generally, most of the babies we have been advising hearing screening at birth. So could you please highlight a little more of that?
Basically, at birth, the test which is mandatory, of course, now it's mandatory all over the globe, is OAE. It tests the function of the outer hair cells of the cochlea. So the result is very easy. I mean, it either comes as pass or refer. So whenever it is pass, obviously you don't have to think about it. But when it comes as refer, it is a screening test. It's not a diagnostic test. So this test has to be repeated. So at 3 months, we repeat the test. And at 3 months, again, if it shows as refer, see, most of them will again come as pass. But if it comes a refer, then it is mandatory to do a BERA. A BERA will then, give you the exact diagnosis as to really whether the child requires intervention or not. So OAE is the basic test. BERA is the test which is done on repeated OAE, giving us a refer result. The next test, which is again really underutilized, very useful in pediatrics, is impedance audiometry, or rightly called as immitance audiometry. This test is again a test which takes just 2 minutes, non-invasive, can be done in newborns also. Then in older children, maybe more than 4 or 5 years, we do the tuning fork test itself. In your clinic, you can know what the hearing is, whether it's a conductive or a sensory type. And children above 5, comfortably, you can do a pure tone audiometry. So these would be the armamentarium of tests that one would perform in the clinic.
Okay. So you already covered a few hearing tests which are available for children, and any other hearing tests which are available and their interpretation. So, and how can we differentiate between conductive and sensory neural hearing loss on the tests?
On the tests, like if when we have done a BERA and we have a hearing loss, so always we have to rule out that whether there's a conductive loss or not. So for that, an emittance audiometry or an impedance audiometry will tell us whether there is any conductive involvement. Because when we do a emittance audiometry, it tells us whether there is fluid in the ear or there's a negative pressure or the eustachian tube is blocked, or if there is otosclerosis or any kind of condition in the middle ear is diagnosed with the emittance audiometry. And another way is that if we cannot really, even we are not sure that whether there is a hearing loss or not, it can be used as a diagnostic test, because normally 85 decibel supra threshold sound, when it given to the ear, there's a reflex spasm of the muscles of the ear, tensor tympani and stapedius, and that causes a change of pressure. And that itself tells us. So if we give for example, a 90 decibel sound and we get stapedial reflex or impedance audiometry positive, which means that the hearing of the child is normal. So you can, infer it in a reverse manner also to reconfirm. So emittance audiometry will tell us all that. And if you do a BERA, you can exactly know where the that's a question falls. Yeah. So which you'll exactly know as to where the lesion is in the middle ear. So if it is not in the middle ear, it has to be retrocochlear. Now a BERA, it is like you can see a ECG, you would have 7 different waves. So when the sound travels from the cochlear nerve to the cochlear nucleus to the superior olive body, lateral lemniscus, inferior colliculus, medial geniculate body. So at all these levels and to the brain stem. So each level, the wave is denoting, and you can know where exactly the lesion would be. In BERA, you would not get a false negative because it's a very specific to every area of the sound.
Yeah, so Dr. Rajesh and Dr. Nehal's questions have been already taken, I think. So
Yeah, I just read it. That's why
yes,
I did.
yeah.
Sorry.
So how to manage sensory neural and conductive deafness, and pediatrician's role in counseling the parents of a child with hearing aids.
Yeah, now if it is a conductive loss, so you have to tell them that this is a reversible loss. They will absolutely become normal. The air-bone gap will be totally closed. So normally conductive loss, the most common cause which we see in small children is usually because of wax or because of fluid in the middle ear, which is serous otitis media. Or if there is, even chronic otitis media, there will be a conductive loss. So all that is totally treatable. Now, if it is a sensory neural loss, it is not treatable, but what we require to counsel them, that if we do not give them amplification of sound, it would result into the auditory pathway not developing. And that is very important. That is criminal if it is not addressed at that age.
Yeah, so as a pediatrician, we must insist on them going for hearing aids or something like that.
Yeah.
And
So,
yeah,
so to counsel them, actually, we have to understand that there is an auditory pathway, and this auditory pathway is normally frozen. And to thaw it, you require sound. So the auditory pathway, if it is not stimulated with sound, if the cochlea does not give sound, the auditory pathway would not really develop.
definitely.
The brain, like we have two centers, we have the visual center and the auditory center. So if there is no sound stimulus given to the child, the visual center takes over the auditory center and the auditory center does not develop. Therefore, in a child, a natural speech development does not grow. It is like a child who is 1 year, 2 years, 3 years. To teach them, talk to them in 4 languages, they will speak 4 languages naturally. Today also, when I have to talk, I will first, I'm more comfortable in talking in my mother tongue, because it is the natural speech development which has, at that age, given me auditory center which cannot occur. It is, and the peak is at 3.5 years. By 5 years, everything is over. So if we lose even a month or 2 months also, we are losing a great amount of time and we are not developing those centers.
Yeah, so in OAE, is it possible to miss a mild hearing deficit And are there any false negatives in OA?
Yeah.
Dr.
OA,
Nehal's questions.
yeah, OA, what will happen that if one has a conductive loss, for example, if there is fluid in the ear, and that itself may, give you a false negative. So therefore, we always have to do a emittance audiometry also to correct a false negative.
Okay. Yeah. So the next question is how to manage a foreign body in the ear. Should a pediatrician try to attempt the removal or should be referred to the ENT surgeon right away? And when to suspect foreign body when there is no obvious history of any foreign body in the ear?
Yeah. And the most common thing which we find is like, if recently also last month, I saw the child is having a ear discharge for like 6 months, and various people have seen. So when the ear discharge is not stopping, what is required is the discharge is to be sucked, and then you find a piece of cotton ball inside, or a foreign body inside. So when it's not responding to medical line of treatment, and the history won't be there basically. So that is the time. Secondly, if the discharge is foul smelling, it's either from a cholesteatoma or from a foreign body inside. So that is the time when you start suspecting that there could be a foreign body in the ear. Now, as far as removal is concerned, it is very easy to remove. There's no need. That's why I told you that if you have a Vectis, if you know syringing, and you have a good headlight, you can remove all sorts of foreign bodies from the ear.
Oh, great. So there are many children who have wax in the ear. Some of them have impacted wax also. And does it need cleaning always, or only drops are enough? Can it be managed at home by parents? And when should the child be referred to ENT surgeon?
See, basically, as you know, wax is a normal secretion of the sebaceous and ceruminous glands, with the epithelium and desquamated epithelium. So it's a natural collection. If you see wax in the ear, there is no need to remove the wax. The wax has a protective function also. So whenever you see wax in the ear, you won't find infections in the ear. So basically, if you just see wax, there's no need to remove unless there are problems. If child is coming with earache, or you feel that the hearing loss is occurring, it's too much of impacted wax. Now, parents can themselves put ear drops and the ear will remain clean. There is really speaking no need to, refer for wax per se. And as far as even syringing is concerned, I would suggest even with a 10 cc, syringe, you can clean the ear. Only thing, while cleaning the ear, you have to take care of some basic precautions you have to take. One is that the water that has to be used should be of the room temperature. It should not be very hot or hot water or cold water, because it will induce a caloric-like reaction. Secondly, the direction of syringing, again, a mistake is should be never directly into the ear. So the wax will never come out. You have to hit it on the side, the water, the direction of flow, either upwards or backwards. Because directly if you do it, the wax will further get impacted. And lastly, after the syringe ear has been flushed out, the water which is remaining inside needs to be dried up totally, because the water left inside will lead to fungal infections. This is how, and basically wax otherwise should not be touched.
Okay. Yeah. So
Ma'am, you're muted. Neeta, ma'am.
Neeta, you're muted, Dr. Neeta.
I'm again.
Mm.
Yeah. So next question. How do we manage acute otitis media with or without discharge? Okay. And what is grommet?
Yeah, see, acute otitis, any otitis media never occurs directly. Otitis media goes through a certain various pathway of clinical stages. So first, there is usually a upper respiratory tract infection. Then via the eustachian tube, there will be fluid in the middle ear, then the drum gets affected. So it has to go through certain key. So directly they will not come. They will say कि पहले सर्दी हुआ था और फिर ऐसा था. That always follows one. Secondly, there is if there's acute otitis media, more important is to clear the nose, to clear if there is allergic rhinitis, if the turbinates are large or adenoid is large. So main attention should be to clear the nose and open the eustachian tube rather than doing something to the ear. Ear drops can be given only as a maybe for a painkiller. You can give local ear drops as such, but apart from that, there won't be any therapeutic use of treating the ear per se. Now, if it is with discharge, then and the child has fever or there is some vomiting and all, then you add antibiotics. But basically, nasal decongestants, nasal sprays, antihistamines are good enough to treat basic otitis, acute otitis media.
Yeah. So what is grommet tube and when do you advise the insertion of grommet tube? Just maybe a little explanation on it.
See, grommet is a hollow tube with flanges on either side. It is not a drainage tube. It's a ventilation tube. So because when the eustachian tube gets blocked, there's a negative pressure in the ear. So whatever oxygen is there in the ear gets absorbed. Then the nitrogen gets absorbed and it creates a exudate and transudate, which leads to fluid. And this fluid is the one which causes the problem. So if we even drain it, do a myringotomy, this is bound to recur because the eustachian tube has not opened. The eustachian tube is not blocked. The eustachian tube is locked. And when it is locked, to reduce the edema, it has to be ventilated. And the grommet is a ventilatory tube. So what we do is we introduce the grommet in the anterior-inferior quadrant, which is close to the eustachian tube. So it has to open the eustachian tube. So the moment there is oxygenation of the middle ear mucosa, that oxygenation will reduce the edema of the middle ear. It'll open the eustachian tube, and normally the grommet remains inside for 6 months. And with this oxygenation, the eustachian tube will open up to prevent future issues. Because if you only drain it, it will recur. And grommet normally comes out on its own with the peripheral migration of the epithelium. The eardrum, the epithelium migrates from the umbo to the annulus, from the center to the periphery. So that epithelium which migrates gets desquamated and forms wax. So taking advantage of this physiology of the drum, the grommet, if you see the grommet after 1 month, it will move a little to the periphery. After 3 months, further to the periphery. After 6 months, it will be out with wax. So as it comes out, so it doesn't leave a perforation behind.
So, Dr. Rajesh is asking, what is Delphi recommendation in acute otitis media?
Achha, okay. For that, I think Dr. Rajesh, what you should do, there is a paper which has just published by, I think, Tanu Singhal and even Dr. Suhas Prabhu. They have brought out this paper on acute otitis media, and they have given all the recommendations in that. I mean, they have come out with this.
Yes, and few children come with ear pain. So, what is the which ear drops for ear pain can be prescribed?
I'll tell you. I to just put local ear drops. We have 4% drops. So you can ask them to put 4% local. That's the best.
Okay.
Like if we're doing any procedure also, like we put local anywhere, drops, either in the nose or in the ear. So you put local drops, you'll get the best. You can avoid the big combinations and all that. The really speaking, no need because it will not help.
Yeah. So in nasal blockages, when you mentioned, so your view on xylometazoline drops.
Yeah, xylometazoline.
Or oxymetazoline.
Yeah, oxymetazoline, xylometazoline can be used, but to a maximum time of 3 days. Beyond 3 days, it should not be used at all. As far as possible, we avoid, but sometimes you have to use it. I mean, when it's an acute phase. So you can use it, but not more than 3 days.
Yeah. So another question about otitis media. Should all ear discharges or ear pains be treated with antibiotics or no?
No, not at all. You don't require antibiotics for all of them unless, that a child spends a full night crying, or there is, a bulging drum if you see, or you can see in a throat, mucopurulent discharge is there in the nose or post-nasal drip. Only then you require antibiotics. Otherwise, if the nose is clear or, that drains off well, antibiotics, really speaking, won't be then needed.
Yes. So, next question, we go to the next question, that is about chronic otitis media. Can you just tell us the management and what are the indications for surgery in chronic otitis media?
Yeah, see, basically, again, chronic otitis media is a sequelae of the upper respiratory tract infection, which has gone to the middle ear and there is a perforation. So, again, you treat the nose and automatically the ear clears up. You see it more in children or in infants especially, because the eustachian tube is short, wide, and horizontal. It's a direct continuation of the nasopharynx. The child spends a long time in the back on the lying down position, and even vomitus and milk tend to get into the ear. So it is important that we teach them to give a propped up position, especially give a good nasal decongestion, and of course, in case the ear discharges quite a lot, then you can give drops so that at least it does not, get accumulated and secondarily infected over there in the ear.
Yes. So, we move on to the next question, and that is an exclusively breastfed child. Okay. When he comes with ear discharge and there is no fever, so how to approach and manage this child?
Yeah, but, basically, otitis media is supposed to be 50% less as far as, breastfed children are concerned. Most important will be again the same thing. It will be a propped up position to be given. So while feeding and even when the child is lying down, that is only the extra thing that you have to add on to.
Okay. So that means you don't need any antibiotics for this child.
Really
If a
speaking,
child.
not, I mean.
Okay. So please about the otitis externa now. So how do we treat otitis externa? Do we require to give oral antibiotics or just the ear drops are enough?
Yeah, otitis externa will require antibiotic only if there is a furuncle or boil or abscess forms and that is causing fever. Only then an antibiotic. Otherwise, for otitis externa, we don't really speaking use antibiotics. The thing we have to remember over here is avoid using the masala ear drops, which is all one size fits all, like, antifungal,
Antifungal.
antibacterial, and wax dissolving, local anesthetic, steroid, everything. So if there is wax, give wax dissolving drops. If it is fungus, give fungal clearing drops. If there is a bacterial infection, you can give an antibiotic ear drop. And if there is pain, try to give local. So a lot of combinations need to be avoided as far as otitis externa is concerned. Because bacterial otitis externa, if you give a lot of all this, they may land up with fungal infection finally. And or if there is just maybe, eczema, it may be non-infective. So just give steroid ear drops also. So try to be very specific as far as ear drops are concerned.
Okay. So can you please explain the significance of deformed pinna in a child?
So when the child, you see a child with a deformed pinna, the parents are worried. I mean, iske kaan ko kya ho gaya aisa. So you just remember that from the first and the second arch, the pinna is formed. From the first arch, we have the tragus. So there, if that is not that is malformed, there may be a preauricular sinus. Now, preauricular sinus, if it is discharging, then requires antibiotics. If it becomes an abscess, it requires antibiotics, and later on this requires to be removed surgically. Or there may be preauricular tags in front of the ear, and these have no connection as far as the hearing is concerned. So you can assure the parents that there will be no problem as far as the hearing is concerned. So that is it, the first. Second part is that if the second arch is affected, the whole pinna is not formed. Now here, the parents are normally worried that the ear has not formed fully, but we have to emphasize that we require the hearing to be tested. So at that point of time, it is important to get a BERA done. So the hearing is most important in a deformed pinna. Now, you know that again from the first arch and second arch, we have the malleus incus and the stapes also forming. So they also will be malformed. So therefore, you can infer that what is happening inside. You have to obviously test the hearing. You have to do a CT to know whether the cochlea has formed or not properly. And also to examine the other structures, because normally with these congenital anomalies, there can be some syndromes or other anomalies also occurring in the child.
Oh, that was really great about
And other thing,
yes.
sorry, Neeta, the
Yeah.
parents may ask you कि अभी कान बना नहीं है, so they are more bothered about the shape. So what to do about that? So what you should tell them is that shape cannot be corrected before they are about 8 or 10 years old. Before 10, normally we don't touch the shape at all, because the pinna is made from the Ziffy sternum, 6, 7, 8 rib. With that form, so you have to wait for the Ziffy sternum to fully form. And then before that, the cartilage is also very soft. So it cannot be done before the age of 10. And therefore, they have to wait till that time, till the pinna can be formed and can be, made. So they may ask you this question. So,
Yes. So this is about ear. Now there are lots of questions in the chat box on adenoids and nasal drops and nasal decongestion. So now let's go over to nose and throat. So first question is on adenoids. When do we treat medically adenoids? When do we treat them medically and when to refer for surgery? And what are the indications for adenoidectomy and tonsillectomy both?
Pretty long question this is. So see, adenoids are obviously they are tonsils, and there's a normal physiology of the adenoids at the age of 2, 3, and 4. So normally also when you remove an X-ray, our radiologist friends will write, adenoid hypertrophy. So that will be, and parents will come to us, ये बड़ा हो गया है, So it is not abnormal to have a hypertrophied adenoid, because from their report, what I mean to say, it's not a hypertrophy, it's a normal physiological enlarged adenoid. So adenoids need to be, you need to consider surgery, especially when there is no air space around the adenoids. And if at all we want to operate, then to confirm, one can get a limited scan done. That will be the best to give us a three-dimensional picture that the whole air space, all around is blocked. Or if there is recurrent ear discharge, which is not stopping, so the adenoid is blocking the eustachian tube, or if the adenoids are blocking the tube and there is a hearing loss where the child is, you can diagnose as you diagnose them as LD, or there's a scholastic backwardness in school. So when the ears have to be tackled and they're not responding to all sorts of treatment, so or the adenoids are so large that there is a dentition change over the upper incisors are over riding the lower incisors, the palate is high arched, and the nose is turned upward, so the facial features have changed, or there's obstructive sleep apnea, and they're going into OSA. So these would be the common indications where the adenoid needs. But then generally before 4 or 5, we avoid doing the adenoids, where the chances that if you do it earlier, not only that they may go down on their own, but there's a very high chance of recurrence then.
Yes. And anything about tonsillectomy, any indications for tonsillectomy, or whether it's ever done now anymore?
Yeah, no, it is done, but as you rightly said, Neeta, the incidence of tonsil surgery has gone down tremendously. I mean, tremendously. Probably you all are treating them very well. So, we don't get so much of tonsillectomies now. The reasons are more, like local, where the tonsils are too large, what we call the kissing tonsils, that interfere in the speech, the deglutition, even the breathing, and OSA also, obstructive sleep apnea. Or there can be focal reasons where there is ear discharge, again, ear not clearing up. And there can be even general reasons where because of the tonsils. There's a septic foci, like, I mean, there's pus in the crypts, and the child is suffering from rheumatic carditis or glomerulonephritis or arthritis, where it's a focus of infection. So it could be even for those general causes. So these would be the causes, but overall it is very less now as seen earlier.
Yes, and Dr. Kamalkar Chaudhary, he's asking, is sleep lab necessary to evaluate adenoid causing obstruction?
No, Dr. KV Chaudhary, it is not, you don't require to do a sleep lab test. You can just put a tongue depressor and see the air blast, I mean, straight away. We really don't ask for a sleep lab test,
Okay.
Or you can do even a plain CT, and the CT will show us that then the whole nasopharyngeal area, there is no, it's totally covered with the adenoid.
Okay. And can we avoid CT if OA is pass in case of deformed pinna? So this question was missed on here.
Can we, sorry, I didn't get it.
Yeah, if a child has deformed pinna,
Yeah.
so can we avoid to do CT if our OAE says pass?
No, but how will we do a OAE if the pinna is deformed? You'll require to do a BERA, you require to do a CT. And if that shows, then you require to do a MRI also to know whether the auditory pathway has formed or not. See, because to do it, the ear canal is only blocked.
Yes. So there are few questions on use of steroid nasal spray in adenoids. So what should be the advocated duration of use of steroids in as a nasal spray for adenoids? Yeah.
Normally for adenoids, you can use the steroid nasal sprays. You can use fluticasone, furoate, propionate. All of them, they have the same or the similar effect. Normally we use it for about 3 to 6 weeks. 6 weeks is the period, where comfortably we use it at a go. And I mean, it is US FDA approved for more than 2 years of age, actually.
Yes. And how long should it be used once we start?
Yeah, once we start, we ask them for 3 weeks. If they're better, we stop it. If not, 6 weeks. But even up to 3 months, you can use
3
it
months
comfortably. There is
max.
no reason. So 3 months, you can use it comfortably.
Okay.
There's no issue with it.
Yeah. So now we go to the next question. That's a child who has a fall and gets a nasal fracture. Okay. So how do you decide about whether to manage him conservatively or some surgical intervention will need in this child? And second question in this is, what are the medico-legal implications if this same child develops nasal deformities later on?
Yeah. So if the child has a fall, first our aim is to stop the bleeding. So the bleeding can be stopped. You can do it, as I said, in a clinic and put a small piece of gel foam inside and the bleeding will stop. Secondly, you have to look for complications, and they are one, see for the eye movement, because the lamina papyracea, the orbit is just in line with the nasal bone. And if the nasal bone is fractured, the chances that they may develop a little proptosis or congestion in the eye. So if there are orbital complications. Secondly, with the discharge, if you see clear fluid coming out, watery fluid, which gives a halo sign on the bed sheet, basically, so that you can suspect CSF rhinorrhea, because the cribriform plate is at the level of the medial canthus of the eye. Thirdly, if there is breathing is blocked, that means there is a septal hematoma. Whether septal hematoma causes the cartilage to get absorbed. So if there is a septal hematoma. And lastly, there may be continuous postnasal bleed if they are, coughing out blood. So these would be the indications where we have to go in for intervention or some surgical procedure. Apart from that, only other indication would be that if the parents are not happy with the shape of the nose. If they're not happy, then the nasal bones we correct. But if there is edema, we have to wait for the facial edema to clear up and then we correct it. And if 72 hours passes, then we require a rhinoplasty at a later date. You cannot do it at that time. It has to be done at a later date. I don't think there are any medical legal implications. You can just otherwise mention on the paper that rhinoplasty may be considered at a later date. So that will save you.
Thank you. So the next question is, what to do when a child comes with a nasal foreign body to our OPD? Again, should we attempt to remove or refer right away?
Yeah, for a nasal foreign body, it is very important that, again, you have a good light. So because if you use a torch or, you cannot actually see into the nose because you will also move. So use a headlight where both hands are free. So good lighting is important illumination. Secondly, the child has to be held firmly in the position that both legs have to be crossed, the parent or the caretaker. Both hands are held by one hand and one hand is on the head to keep the child straight. So keeping the child in a fixed immobile position is very important because you will have just 1 second to do it, less than a second. You won't get a second attempt because the second time the child will not allow. So you have to assure that you have a good light so that you can see inside. Secondly, movement should not occur. Thirdly, you should use a right instrument, again like a Vectis or a hockey stick. And commonest mistake is that we tend to hold it with the forceps. Any foreign body, in the nose, if you hold it the forceps, it will go inside. And once it goes a little inside, then it's not possible to remove it. So first attempt is the best attempt. So the thing is that with a hockey stick or this instrument, go behind the foreign body, take support of the foreign body and bring it out. So even if the child moves, the foreign body will come out on its own. So you can remove it yourself on your own in the clinic.
Nice. So the next question is about bronchoscopy and tracheobronchial foreign body. So can you please explain the details of dilemmas in suspected tracheobronchial foreign body? The role of rigid versus flexible bronchoscopy. Should the bronchoscopy be preceded by virtual bronchoscopy?
See, first of all, virtual bronchoscopy has no role.
Okay.
If the child has to undergo a virtual bronchoscopy, I rather do a bronchoscopy in 2 minutes. It's lesser time, I'll finish a bronchoscopy. One. Secondly, we have got patients where virtual bronchoscopy has shown there's a foreign body. We've done a bronchoscopy and not found anything inside. And vice versa, that is shown that it is normal and we found a foreign body inside. So false positive and false negative, both we have seen with virtual bronchoscopy. And if you have to do a virtual bronchoscopy, might as well do a bronchoscopy only. So virtual bronchoscopy is totally out. Second was, you said rigid and flexible.
Yes.
Now,
the role of flexible versus rigid bronchoscopy.
We do both the bronchoscopies. We do flexible as well as rigid. But personally, I would tell you that a rigid bronchoscopy is much more safer than a flexible also. And the main reason is that by doing a rigid bronchoscopy, the ventilation channel is very good. So you're not worried about the saturations. Secondly, the channel is so big that suctioning can be done easily. In flexible, the channel is very small for suctioning. These thick secretions in LRTIs do not, happen so easily. You really do struggle with that. And thirdly, if there is a lesion, like even a granuloma or a polyp or a impacted foreign body, you can maneuver easily because you get good forceps space with a rigid. So even though we do both, but rigid is actually safer and better. So you can label it like when I do a flexible, it will be only, we do it as a diagnostic one. But when we are putting a rigid, we can do a therapeutic at the same sitting. And many a times when we get patients for lavage, BAL, what we call bronchoalveolar lavage, we do a scopy to take a lavage and we find a foreign body inside. So we are not gone with the intention of removing a foreign body. Patient is for, a lavage. but lands up with a foreign body. So many times chickpea seeds and all these vegetable foreign bodies are inside. So therefore, I would suggest a rigid. We can not only do it in infants and newborns. I mean, the lowest rigid is I have done it in 900 grams preterm also. Where amniotic fluid aspiration was there, lung was not expanding. Put in a 2.5 rigid and cleared the lung. So you can do it at that level. So you can do it for any child, I feel. Now the dilemma is with the foreign body bronchus is, first of all, that there is no history available. The child is smarter than the parents, child is smarter than the caretakers. Secondly, the signs always keep on changing. When you see them at different stages, the signs keep on changing. Thirdly, the signs keep on mimicking various diseases. Initially, they are treated in the first week as laryngotracheobronchitis. In the first month, they are treated as pneumonias. Then after that, for 3-4 months, they are treated as asthma. After 6 months, they are treated as tuberculosis. After 1 year, they are treated as MDR. They are as MDR TB. We have got so many patients, we see once or twice in a year who are MDR TB, and we have done it and removed a foreign body. So at different levels, when a foreign body presents to us, they are actually labeled with a certain medical condition, and that medical condition turns out to be a foreign body. And even in a foreign body, it is the clinical acumen which is most important, because I've had foreign bodies where, forget even bronchus, even which are there in the throat, they admitted 4 times in different pediatric hospitals, and I found a chest pawn inside, and twice CT scan done, twice MRI done, 4 scans done, not picked up a foreign body. So it is not that the scan is the gospel truth. It is the foreign body, it is not picked up by certain scans. So finally, it is how one, if thinks of it. And foreign body, we have found everything under the sun. We've had so many times, I've seen foreign bodies where children have, the last one I remember, he's went to McDonald's, had a hamburger, this boy, and landed up with cough. And he was finally landed in the ICU, didn't remove. Then we did a lavage, and in the lavage, I found chicken fibers, chicken pieces. So, you find rice inside, you find so many things in the bronchus which are taken for lavage, and we find a foreign body inside. So this is the problem, that it mimics diseases, and you can definitely label it as X, Y, Z medical condition, and you can treat it with that. And they do improve with antibiotics, they do improve with steroids. Band kar diya, to then they recur. And then the doctor also changes. So it makes things more difficult.
Yes. So basically, diagnosing a foreign body is really, really very difficult when there is no clear-cut history. So picking up, but only the clinical suspicion, I feel, is very important. The next question is about laryngomalacia. So we all pediatricians diagnose laryngomalacia very commonly. Okay. Is it enough to just reassure the patient after diagnosis of laryngomalacia, or we need to do any further evaluations?
Yeah, earlier the term congenital laryngeal stridor was synonymous with laryngomalacia, but that is not right, because what we get a lot of the laryngomalacia is very, for a diagnostic scopy, and we find cyst inside, valvular cyst inside, papillomas inside, hemangiomas inside, lymphangiomas inside, vocal cord paralysis. So number of, because till we don't know what is there inside, it is labeled as laryngomalacia. So patients on the list, children are coming to us as laryngomalacia, because it's not a diagnosis. Even though it is common, but it is not that every child with this has laryngomalacia. In fact, the last 2 years, we had about 25 valvular cysts, where just the cyst is just, put a needle, drain it, and they become normal. So laryngomalacia is, many of them are wrongly labeled as laryngomalacia. What I mean to say is because they've been not seen inside. So it is probably, in fact, we even had recently a web, that is a laryngeal web, and it's treated as laryngomalacia, and all of them are then on calcium positioning and all those things, etc. So laryngomalacia is not everything. There are a lot of other things apart from laryngomalacia. That is all.
So they have to be evaluated, all of them. And they direct laryngoscopy should be done in all of them, at least.
Yeah, I mean, because since you don't have a diagnosis, you can't write that this is laryngomalacia, and well, many of them don't. I mean, for example, some of them have a small hemangioma inside. You put them on propranolol and that disappears. I mean, they have cyst inside. So you just, So
Yes. So the next question is about hoarseness of voice in a child. Okay. Now, a child comes with hoarseness of voice. So can you please tell us how to approach and manage this child, and also brief us about the use of direct laryngoscopy for these children?
see, the most common reason of hoarseness now, what we see is because of allergy. They have granular pharyngitis, the larynx is inflamed, and they have typically, this allergic condition, or in school, I mean, because of shouting or after a picnic or after a match, they may develop laryngitis. The only thing is, if they don't clear up, for example, in 3 weeks, then one should can consider, or it's a worsening, then you can consider a scopy where we may find nodules, polyps, or even a papilloma inside. There could be even a vocal cord paresis. I mean, that is seen quite often. So and that vocal cord paresis would be only a symptom of some other condition. It could be a pulmonary condition which is pressing on the recurrent laryngeal nerve, or a cardiac condition, or I mean, so this is only a symptom. It's not a diagnosis.
Yes. So again, hoarseness of voice also has to be investigated in details. A child, a small newborn. Okay. So what are the respiratory emergencies which we can, ENT related respiratory emergencies in a newborn child, which we can suspect?
See, first of all, one emergency is a very grave emergency. In fact, we've also, lost a child, I mean, on delivery, where they called us, which is, of course, all of them now do a antenatal anomaly scan, like, maybe, in 19 weeks and all. So you have to see whether chaos has been ruled out or not, because quite often we see even this chaos, congenital high airway obstructive syndrome. In fact, recently in our hospital, just look, we had the sonographers rang me up. He said me, so these are twins, and both have chaos. So I said, I mean, obviously they can't continue. So we have to be aware that maybe after birth, because many of them don't do the anomaly scan, I mean, before 20 weeks. So chaos is one thing, of laryngeal agenesis, where after delivery you can't really do anything, because in that time period the respiratory distress is really a emergency. Secondly, children are obligatory nasal breathers. So we have to think of, if there's a choanal atresia, the bucconasal membrane is present or not. So if there is bilateral choanal atresia, then immediately, you have to put a nipple in the mouth with a wide pore, so that breathing is maintained. Or there could be in newborns, like teratomas, encephalocele, meningocele, which is causing a complete nasal block. So these are actually emergencies in a newborn.
Okay. So there is a question by Dr. Rishabh Shah for a child having recurrent pharyngitis, how to manage?
Yeah, recurrent pharyngitis, most common cause is actually, allergic rhinitis, where there is a turbinate hypertrophy. And this turbinate hypertrophy leads to two reasons. One, there's a postnasal drip, which causes granular pharyngitis. Secondly, when the nose is blocked, they breathe from the mouth. And the function of the nose is to filter the air, clean the air, moisten it, and take it down to the throat. So when they are mouth breathers, all the atmospheric dust, pollen, pollution affects the throat and causes granular pharyngitis. So primarily treat the nose, and you have to allow nasal breathing to occur. And when you allow nasal breathing to occur, the throat will clear up on its own. This is the majority of the children we find this, but still you would say, about maybe 20-25% of them may have you'll have to suspect whether there is GERD or not. So there can be associated GERD, which needs to be tackled.
Yeah, so as you rightly said, our next question is on, many children who come with recurrent throat irritation, and we are sure that it is not infection. So do we really consider GERD in children, and how commonly you come across GERD related throat in pediatrics?
Yeah, that's what I said, that supposing what you can say about 25% may be GERD and 75% would be because of allergy, upper respiratory tract allergy to that tune actually.
Okay, so it need not be treated with antibiotics.
Not at all, not at all.
Okay. So do we have time? One more question. Yeah. Yeah. So it is about management of DNS and counseling a patient with DNS in pediatrician's OPD.
Basically, as far as possible, we avoid actually surgery in DNS in very small children. The youngest that is advisable is beyond 7 or 8 years of age. Now that too, it has to be only thought of if there is no meaning, the child is really in distress, the nasal block and the sinusitis and respiratory tract infection is not clearing up. Otherwise, wait till the age of 12 and then, can think of a correction. But in very small children, we don't do it because the growth centers may get affected, because the nasal growth center, the antenasal spine from where the septum and the nasal maxillary process grows, we don't want to touch that as far as possible. Yes.
Yeah, so generally surgery should be advised only after 12 years.
Yeah, better. Yeah.
Okay. Yeah. And about the management of nasal polyp, how would you go
Yeah.
about
So
it?
for nasal polyp, there are two different types of polyps, as you know. In the infants and in the younger children, we only see ethmoidal sinusitis. And classically, the etiology is allergy. So there are polyps which are bilateral, multiple. And many of them, you'll be surprised, they come with actually, they go to the ophthalmologist because they come with eye congestion, they come with eye swelling, they may come with proptosis, they come with orbital abscesses. So at the age of 1, 2, 3, 4, 5, you will find ethmoid sinusitis. So these are ethmoidal polyps. Secondly, in the bigger children, in the adolescents, where the maxilla is fully developed, they come with an antroconal polyp. Antroconal polyp is infective. It is always single. It's always unilateral. And the treatment is only surgery removal. No medicine will work in an antroconal polyp. While ethmoidal polyp, you can give steroids and give it a trial for ethmoidal polyps to clear, unless they come with orbital complications.
So I think we are done with the questions. There are no questions in the audience. So
Nita, some of the earlier audience questions you can take, just scroll through and see if you have missed something.
yeah, I think most of them I have taken. So there is one question is oral decongestants like phenylephrine in common cold drops or syrups effective and safe?
Yeah. The effective and safe, you can use them, but what happens if, like I just read one question now also. The steroid nasal sprays work much better,
Okay. Yeah, I think nasal decongestants you have already said we can use xylometazoline or oxymetazoline. Nasal steroids also is done. Chronic allergic rhinitis. So treatment for chronic allergic rhinitis has been asked about Dr. Rishabh Shah.
The most important part of treatment. In fact, last month I've just done a podcast on this. I'll send it to you, Nita. Chronic allergic rhinitis. So first, most important is what we tell our patients is avoidance. Avoidance is the key to all that. So first of all, stopping chocolates, colored drinks, packed food, ultra processed foods, which stop all that. In the house, nobody uses perfume scents or deos. They change the soap that they're using. No mosquito repellents and all to use. No, I mean, the standard thing, no good night all out or,
पडशी म्हणून समजेल कोणाला सगळ्यांना दरवाजा उघडलीस तू
Dr. Uday, can you mute?
Muted.
So basically, avoidance plays the key to it. Secondly, the gold standard of treatment in allergic rhinitis is the nasal sprays. They are the most effective as far as this is concerned. And not to overprotect them, basically. Because a child who's playing football on a rainy day on a muddy field does not get an attack of allergic rhinitis. But a child who's in a well-protected bedroom, nice air-conditioned bedroom with a quilt, gets an attack of allergic rhinitis. So it is our friends who come, we see every week somebody who comes from so-called affluent countries like whatever, US or UK. They land here and their children come straight away, with nasal discharge and all. But our children here don't get it. So genetically, we are the same. They are not different genetically. So it is the hygiene hypothesis also which plays a big role in this. So not to overprotect or overtreat our children on. So that is, and we require them to breathe from their nose is most important for allergic rhinitis, because childhood allergic rhinitis not treated obviously leads to adulthood asthma. So you don't want them to be mouth breathers. Just their nose is open, they're breathing, it'll protect their lower airways.
Yes. So I think all the questions have been taken.
Nita, may I one?
Yes,
Sir,
sure.
actually, sir, what I was asking was in OAE. Is there any reason where you will get a false pass? So what I mean is the child has a hearing deficit and it is not picked up on an OAE. Is that possible?
No, it is not possible.
Okay.
Yeah, because it's
So-
the outer hair cells. So there is nothing to interfere.
Sensitivity is like very close to
Very
like you can
close. Yeah, exactly. OA
even
is
for
just like-
milder deficits, sir.
Yeah,
Even
yeah,
for
it'll-
milder
It'll
deficits.
pick it up. OE won't give a false negative. OE is, in fact, even for, now when we put the children on AKT, we're giving certain autotoxic drugs, for example. When you're putting them on Canna, Genta, Strepto and all that, audiogram picks it up much later. So what we do is after a week or two, I'd ask them, you do the OAE only, and then you can tell them, the hearing is OAE is pass, so you can continue with the medication because they have to give it for a longer period. So OAE is the thing which first picks it up. It is not only sensitive, does not give you false positive or negatives. And in a test in 2 minutes.
And
Yes.
minimum period that you need to redo a refer.
3
So you
months.
retest a refer.
Normally we do it at 48 hours after birth.
48 hours
And
immediately.
yeah, and if it is come as refer, then we do it at 3 months and then 6 months, basically. Because even when we do a CI, an implant and all, it is normally obviously after 6 months.
6 months.
Yeah, so 8 months, 10 months. So, we give a 3-month period to repeat a OAE.
There is one more question. If recurrent bouts of cough are present, should we consider an allergen testing?
So you don't know what the result is. You can do it, allergen testing, but and if you can identify it very well, of course. But recurrent means how recurrent, or so. See, normally it could be even GERD also, causing it. So
Yes.
depending on the clinical picture, you decide whether allergen testing is required or not.
Okay. And
And sir,
another
for a
question-
general,
Yeah.
Yeah.
Neha,
Sorry.
you.
no, sir, for a general pediatrician, it was a little this thing eye opener that most of the cases of laryngotracheomalacia, or what we used to call it as a benign laryngeal stridor, even when a child is thriving well, should undergo a scopy and find out if there are other causes to it?
If the stridor is not clearing and just continuing it as laryngomalacia and on calcium for months and months, it is better to just put in a scope and know what is there inside. No? Because we find so many other conditions which are, I'm telling you, even laryngeal webs we've got as laryngomalacia, and we've just just split open the web and they become normal. There's a hemangioma, or you start them on propranolol, or if there's a valvular cyst. We've had 25 valvular cysts in the last, 2 years. So, which are treatable. And only thing is, if it is not clearing up, only then. When you
So,
just
any red flag in terms of duration? So, suppose you have a stridor which is remaining the same till 5 months, 6 months and beyond, then maybe you may consider.
then you may consider, yeah.
Yeah. So I think Dr. Rishabh's question has been answered about bronchoscopy. The question was asked. Yeah,
Rajesh,
so do you have any questions, Rajesh?
No.
Sir? Okay, so like I would like to just summarize some take-home messages which Dr. Divya has given. So for pediatricians, headlight, otoscope, vectors, syringe, nasal hook, and gel form are necessary to be kept in our office practice. OAE, if it is pass, nothing to be done. If it is refer, then you can do BERA and it can be repeated after 3 months. Impedance audiometry is done for conductive hearing loss, and sensory neural hearing loss is detected by BERA. There are no false negatives in BERA. No need to remove wax unless it is impacted and it is causing hearing issues. Acute otitis media. So in case of acute otitis media, we should treat the eustachian tube and nasal blockages and not just the ear. And today I really realized Grome tube is a ventilatory tube and it's not a drainage tube. So that has to be kept in mind. And never to use masala ear drops. And in a child with deformed pinna, we should do hearing test, which is a must, and also the CT scan to know about the internal ear structures. For adenoids, limited scan should be done before we go ahead with surgery. And virtual bronchoscopy has no role and in treatment. So if you do rigid bronchoscopy, then you can do diagnosis as well as therapy both. And whereas flexible bronchoscopy is preferred mainly for the diagnosis purpose. Clinical in foreign body, clinical suspicion is very, very important. Otherwise, it is very likely that we can miss them. And all laryngomalicias and stridor, which have a longer duration without any improvement, they should be referred for direct laryngoscopy to the ENT surgeon. Thank you.
Thank you very much.
Yeah.
Rajesh bhai.
Oh, thank you, sir. Sir, on behalf of IAP Mumbai, we express our sincere gratitude for accepting this invitation and sharing our expertise and gave us such beautiful insights into the pediatric ENT disorders and empowering us to improve our pediatric ENT practice further. Thank you very much, sir.
Thank
I
you,
also
my pleasure.
acknowledge, thanks, sir. I also acknowledge the presence of Dr. Amol Pawar, Secretary of Maharashtra IAP. Hello, Dr. Amol.
Hi everyone.
Yeah.
Good evening. Good evening,
Hello.
Chokan sir, Divya sir, Nita ma'am, everyone.
Yeah.
Hello.
And we express as special thanks to Dr. Neeta Jagat ma'am for navigating this question so well and giving such crisp carry-home messages. Thank you very much, Dr. Neeta. And we, of course, acknowledge the presence of all our audience. And before I wind up, I also wanted to make a few announcements about our future programs, the forthcoming ones. We have our GEME module, that is Gastrointestinal Emergency Module, made easy on 10th of November at Hotel Orchid. on Sunday. After that, the most awaited annual conference, the MBCon. This time it is going to be a combined conference of Mumbai as well as Navi Mumbai, and it is called Navi MBCon. This is scheduled on 30th of November and 1st of December at the Interlink Banquets at
Vidya
Vihar, sorry. And so please book your seats before the registration go full, because it is one of the most awaited scientific conference of Mumbai and Navi Mumbai. And after that, we have one program by the respiratory chapter of Mumbai IAP at along with IAP Mumbai at SRCC hospital, that is on CT scan in respiratory medicine, that is on 8th of December at SRCC hospital. So thank you all for
and
joining us.
RVIC. Rajesh bhai, RVIC.
Yeah, the respiratory virus infection RVIC module, which is scheduled on 15th of December, that is going to be at Andheri at Hotel Park View. That is a model from the central IAP. Yeah. So
And one more, sorry, one more.
Yeah.
IAP Mumbai to represent at the state sports event, which is going to be hosted at Nashik, is it?
Yes.
So whosoever is attending today and all your friends and contacts in all the zones, please, this time we want Team IAP Mumbai to go and represent at the sports. So further details we will share on the groups.
So thank you all for joining us, and I think we'll conclude with this meeting. Thank you. Thank you very much.
Thank you, Dr.
Thank you, sir. Thank you very much.
Thank you.
Thank you. Thank you, sir.
Good night. Good night. Thank you.
Good night.
Yes. Rajesh sir,
Oh,
this cricket team, tennis ball cricket team.
oh.
We won tennis ball cricket team with 12 to 13, at least 12 to 13